Session 6, and we'll finish up meds, and then this is a demonstration day to do all the rest of nursing that we might need to be reviewed on. So we're going to finish medicines, go to briefs, page 20, top of the page. Macrodantine is the medicine we'll start with in just 1 second. What I wanted to say is about the video, the YouTube. Has anybody watched the YouTube clinical decision making? You have, Robbie. And so it's what you're seeing today also is on the YouTube there, but you can also pull up session 6 if you needed a review. And Daisy will go over all that with you. So let's start with macrodantine, and it's urinary anti-infective. And just to remind you of anti-infective, I'll sit for this part. Anti-infective, remember, makes the milieu, the area around the problem or the virus or the whatever, the culprit, it makes life not bearable and viable. And so it doesn't kill, but it's an infective. We've already discussed antibiotic versus anti-infective. And I do think it's good to know if used 6 months, it can cause lung fibroids. I gave a lot of that to paraplegics, and
I remember that back in the day.
And it's still a good old drug used. It is an old drug, but it is still a good one if you don't give it for 6 months. Magnesium, if potassium's low, the IV magnesium can sometimes be ordered along with supplemental potassium. When both IV and magnesium and IV potassium are ordered together, we administer magnesium first. And let's just review our KCL runs. Remember, I'm just reviewing, because the runs, if our potassium is 3, we want it 3.5 to 5. If it's below 3, the physician's worried because that's that relationship with nerve and muscle, and the biggest muscle being our heart, and that's what they're scared of, arrhythmia and then heart failure. So they need to get it in fast, so they do the runs. 10 milliequivalents over an hour, and it's a run. If it's in peripheral, we dilute it in 100 milliliters. If it's central line, it can be more concentrated. It could be 10 milliequivalents in 50. They don't usually do just one run. They do usually 2 or more. They need it fast so the heart won't get out of rhythm, but they may also give it PO. And at the same time, PO potassium and IV potassium. This is, and the magnesium and potassium, as is pointed out, have a relationship. And the potassium may not be, the magnesium may not be down, but the point is, because of their relationship, the physician a lot of times will order some magnesium runs, or a couple of grams, and they usually 1 gram is in a run of magnesium. And we're saying, I used to think when it was ordered, I thought, well, I want to give the potassium because I want the heart not to go out of rhythm. So I would do the potassium until one day a pharmacist or somebody said, if you've got them both ordered, always give the magnesium first. And it may not even be off, but if they're ordering them both, it's just something about the relationship to give the magnesium first and then potassium and magnesium and potassium, usually a couple of magnesiums. Meprogan, it's a combination of oral form of Demerol and Phenergan. and really a good drug for PO. Because the Phenergan kind of enhances the Demerol. There's NaCl H2O, salt water, sodium chloride, and water, and there's hardly anything better for mouth sores. And on my floor, which is oncology, they keep the salt and soda there, soda mixed with it. It's just always a teaspoon to a glass, or maybe even a quart, but I think it's a quart, but it doesn't matter. It's just so medicinal. Salt is just so medicinal in those mucous membranes. Narcotics, the standard question, I don't know what that FLACC, do y'all? We just asked for the ranking. What does it stand for?
I don't know what it stands for.
I don't either, but the ranking is your pain 0 to 1 to 10.
I think the face something like
What?
if they cannot verbally tell you,
They
how
have
the
the
pain.
smiley faces.
Yeah.
Oh, yeah.
That's
A face
scale.
kind
Oh,
of
the
thing.
spaces on the scale from 1 to 10.
Yes.
Yeah.
If they
Oh,
hurt
the
you,
leg-
they
Crying
Yeah.
to,
Yeah.
Oh, yeah,
Yeah,
the
it's a
face
face.
is like crying or laughing
Right. Yeah.
or whatever.
You're
So
right.
it's faces
Mhm.
if they can't verbalize
Mhm.
0 to 10. Nebsen is tobramycin. It's a sulfate drug and will not mix with anything. And I hope pharmacy will alert you of that. Otherwise, kind of bed it down in the head that, we've already talked about it, but just keep your finger there, but go back to page 18 in this. And we've already talked about it, so my memory's not lost. I know we've talked about the fourth drug down is dilantin, and we've already talked about don't do dilantin and dextrose because they'll kind of clabber. And I remember I hadn't given dilantin in ages, and I got a report, and I knew there was something strange about, that's all I knew. When she gave me a report, and it was hooked up and everything to be piggybacked later in the night, but I just knew there was something about dilantin. And I did say to her, what is it? Isn't there something peculiar about dilantin? And then she repeated. Thought would have been nice if she'd said it in report, and I wouldn't have had to ask. But I'm just telling you, make that embedded that if you can't remember tobramycin, there's something about tobramycin, and it is that it just needs to be all by itself. It doesn't need to be with any other drug. And we've already talked about Numega, which is the sub-Q that increases platelets. And then they're right there with Neupogen, which increases WBCs. They all are called GSCFs because they stimulate the MARA to growth-stimulating colony hormone to make white cells in the case of Neupogen and platelets with Numega. Neurotin, or AKA gabapentin, anticonvulsant, also used to treat post-hepatic neuralgia, and I think we've already talked about antidepressants, just increasing a blood flow, which puts oxygen in, Neurotin does the very same thing, and that's why they would hope you don't have convulsions, is there's a good blood supply being into the brain area. Nitropase, if it's a patch, which this usually, they'll put it, now they're using more patches with it on, but they still have the little piece of paper where they want to squirt out an inch and put it with a piece of paper on the chest, and then you could put saran wrap over it. We just now did a patch on a man, one of the nurses and when she took the old patch off, and put another one on another place. And I always wipe off the area with an alcohol to get body oil off, because the patch has got to work through body oil before it can get to your skin, which then lets it in. So it's got a long path, and I don't know how long it takes to get there.
Yeah. Is
But-
the patch more effective than the other way with the saran wrap?
I don't know. I think they've gone to patches
Oh,
more.
okay.
Mhm. And he said to us, "Whew, when you take that off, it itches so bad." So I said, well, let me get some alcohol and just wipe that area where she took it off. So I say, wipe before you put one on, but maybe we need to wipe certainly one you took off and get excess off. And we've already talked about Oferva. Are y'all doing it at Vanderbilt? Do you know if you're using that at Vanderbilt?
I don't think,
You don't know that you are. Okay. Like I said, I'm not seeing it done, but I know it's effective. The IV Tylenol and we mentioned last week, the IV Tylenol and the IV ibuprofen both work great, but I think they're expensive and I don't know why. Oxycodone, oral morphine, and let me just say, now I'm getting a little political here, so excuse me. I'm not necessarily for Barry Sanders, is that his name? Sanders. Medicare for all, the word sounds too much to me and too expensive. But our son quoted yesterday to us a Yale study that said, can you give any quotes?
I tried to forget it because I didn't agree with him, but anyway, he said we're spending about $850 billion on medications each year.
And that would cover Medicare for all. Is a Yale study, is what our son was saying. But Bernie Sanders, if you watched the debate Tuesday, said drug companies made $400 billion or something. And I think I told you, Michael Moore's film on drugs or Sick, his film Sick, I think I told you, he said in Cuba you buy an inhaler for a nickel, but it costs $120 here for that same inhaler.
That's why all the elderly are going to Canada, taking buses once a
Oh,
month to Canada
no,
to get their
really?
medication.
Really?
Yeah, when I lived in New York, they just go right over the border to get their medication.
Wow.
Yeah, I live in New York too. In Canada, I think they got free healthcare. You can go to Canada and Germany and get free
Yeah,
healthcare.
they have
go up there.
socialized
Yeah.
medicine.
So I don't know. I just know it is out of sight. Medical care in this country, I don't know what to do. We just go on and take care of people. Percocet, I think we've been over it, but just again, it's acetaminophen. Only 325 though, acetaminophen and oxycodone. Phenergan, also called promethazine, and dilute it with saline because it damages the veins and stings when given. And 1 milliliter of Phenergan with 2 milliliters of saline for IM. But dilute more for IV. You can dilute as much as you want to if you're going to IV push. Can't dilute it as much as you want to for an IM. But just realize how painful, and that it does scar the vein when it hurts. And I'm so sorry because I forget if I've taught you all or the Wednesday group, but the lidocaine, did we discuss?
Give it
The
C-J.
lidocaine can be put in it, and the potassium too. Potassium, we said the same thing. The pharmacy can put some lidocaine, not at your request, it has to be the physician. But it's still gonna burn and scar, it just doesn't hurt you. And that vein will be hard by the time you leave the hospital. It'll be hard because it's been damaged. And so I'm not a big lidocaine fan. Well, you can order lidocaine and they'll do it, and they will. But it just got to be slowed down if it's hurting. Just slow it down and make that damage less. Piperacillin, and the biggest thing is it decreases our potassium. I mean, it's a great antibiotic, but you just got to be aware of that. And you know, it doesn't hurt you to tell a patient that and give them a banana. Say, with that, an orange juice or something. You don't have to give them a big lecture, but just push it that way. Potassium, we've already talked about the runs. Will increase quicker than oral. So, you know, a physician will often give oral and IV or the runs. Lyrica or pregabalin, anticonvulsant. And it's anticonvulsant, but it does the same thing. I think it's given more for neuralgia, for neuropathies. And it's just the same reason. It shoots that circulation in the area. So what did we say pain mostly is? Areas not getting oxygen. And pain is, so if I open up and make more flow, I'm carrying more oxygen and more nutrients. So if I'm doing that to keep convulsions from happening, it can also help circulation and neuropathies. Procardius SL, gelatinous pill, contents are squeezed out, and calcium channel blocker. It decreases blood pressure. And SL is, of course, sublingual, just to remind you. And then just remember what I told you. If they're still sending, I think I've already told you about the syringe, giving it and shooting air. Is that ringing a bell? So remember, put a syringe with air. Here's your gelatinous. Go all the way through with the needle. Bring it back right halfway. Go into the patient, under the tongue, and shoot the air with that gelatinous coming out the other end. Pyridium, just keep in mind it is wonderful for pain, but it's palliative. Palliative takes care of symptoms, but not the cure. So it's not a cure. It does turn the urine orange. Now let's go to Reglan. It's for you always think Reglan GI, used to increase gastric motility. I hope the pharmacy will put on that it's photosensitive. And then pheochromocytoma, we've already brought that up. It will, Reglan's side effect, it increases blood pressure. And and a pheochromocytoma is that tumor on the adrenal glands, and we'll talk about that. The last session is endocrine, we'll do. And also it's on your YouTube, endocrine. But pheochromocytoma sits on the adrenals, and the weight of them pushes and on the medulla, which produces epinephrine. So it shoots the blood pressure up. And if you give somebody that has a pheo who already has a high blood pressure, and then you give them Reglan, then you have just about blown their brains out with circulation. And it does need a brown bag because of photosensitive. Relistor, I think we've talked about that one, where you can give the sub-Q for narcotic-induced constipation. We've already talked about it. Sandostatin, used for fistulas or heavy secretions of tissue, a wound, not vaginal, not any other thing. It's a wound. Secretions are heavy, Sandostatin. Senecot, stool stimulant. And then Senecot S softens and stimulates. Salumedrol, and I thought I had one I'm going to show you. I may in my box, but it is a steroid, because drop your eyes down to steroids and you see it, you should, Medrol or Soluben. And it's just telling how to do it. I may have it to show, but it comes with the fluid in the top, the powder in the bottom, and you push a stopper that makes a mix. And be sure and roll when you're mixing, especially if you've got to measure, because we don't want to try to measure suds and foam. And then we've already been over steroids. They're just some examples. And then, of course, steroids, they coat the platelets so the spleen won't kill them. And we'll talk more about that when we get to endocrine. Anti-inflammatory is their most famous use. You need to taper them off off as you administer. You don't stop somebody abruptly, and we'll talk more why when we get to endocrine. Retards growth of cells. That's why people on steroids have the thin extremities and the thick midriffs, the buffalo neck and the chipmunk jaws, because it's a redistribution of fat, and the skin's so thin, so they don't heal real great. Ulcerogenic, meaning it does cause ulcers, but not just in the GI. They cause any kind of ulcer on the body. And of course, other than anti-inflammatory, probably the other most known thing about steroids is the hyperglycemia, the sugar, high sugar. Those are your two most known things that steroids do. They do increase appetite, they increase moods, decrease healing, and you know that because we've just said retard growth of cells. Skin flushes a lot of times if you're on them. And then I think we've talked about causes the anal spasm or the vaginal spasm if IV's pushed too rapidly. Double length of time to IV push. My thing is 0.5 milliliter over a minute pushing. But if it's a steroid, 0.5 milliliter over 2 minutes. Now, if they give you permission to give it faster, we give an antibiotic on the floor that is 10 milliliters, and the pharmacy sends word on the MAR, medication administration record, give over 3 minutes. So we can give it over 3. Well, I do anything pharmacy asks me to do, but if they don't tell me how fast, then I do my 0.5 milliliter or whatever. Tegretol, anticonvulsant, treated lots of times for facial pain. There's your tetracyclines. Avoid milk or calcium containing products or iron containing products for at least 3 hours after taking. And there are the drugs that interfere if we do calcium or milk. So you just need to wait and let it get out of your stomach. Thorazine, and it was tetracycline we mentioned, wasn't it? In the old days, you couldn't let it touch your teeth. Mm-hmm. It would turn them dark. Thorazine can be used for hiccups. So if somebody has hiccups and they just can't get rid of, just remember that Thorazine can. Uracid is anti-infective, and it's palliative though. It's the same as Pyridium, but it's better. Pyridium isn't even anti-infective on page 20 at the bottom. It's just strictly makes you feel better, Pyridium. But Uracid has some anti-infective properties, and it is palliative. Makes definitely feel better, and it turns the urine blue-green. Valium or diazepam, very thick to the veins, and it's used for withdrawing from alcohol use. So IV Valium you'd want to dilute because it is toxic. We've already talked about Victoza, which was the one that was used once daily, but those are going by the wayside for the one that's Bydureon, that's once a week, or any of those once a week ones for diabetic control. Vitamin C, and we've already talked about it. Iron needs vitamin C, but vitamin C doesn't need iron. Vitamin D prevents or treats renal bone disease. And for a long time, we couldn't get vitamin D except from the sun, isn't that right? But they're saying things are fortified with D now. So just keep that in mind. A lot of people say people that have osteoporosis, it's not the bone calcium they need, it's D. And they say the best thing people can do is be out in the sun 15 minutes a day, and that would help the D aspect. Vitamin K is an antidote for therapeutic INR-PT. You know, if your international ratio or prothrombin time is getting too long, it's taking too long to clot, K, I think most of us know, help in clotting. And as far as foods with vitamin K, I'm not sure. Do you all know? I want to say,
I think greens.
Do what?
I was gonna say the same thing. I know green leafy vegetables.
green vegetables
Spinach.
are good in K. Okay, thank you. Now that you say that, I remember. And then warfarin or Coumadin, and we've talked about that. Old drug, still being used. We said that we've already talked. You know, I'm just repeating a few things we've said. But the best thing about Coumadin is it has an antidote, and that's K. The worst thing about our new ones, Plavix and some of those, what's the one with the L? Eliquis. It's not an L, but it sounds L. Eliquis, and some of the newer ones don't have an antidote. Xarelto. It's one of those that doesn't. It's one of the new ones that does. People love them because you don't have to get your blood checked every 6 weeks. But the bad part is no antidote. And we've already talked about Xeroxolin, which enhances diuretics. You don't take Xeroxolin by itself until you've kind of reached your limit on how much diuretic and how much Lasix, and you've kind of reached your limit, and so Xeroxolin will enhance it. All right. So I think that's all on medicines. You've got, everybody has a phone that they can Google medicines, and that's the beauty of now, living in this day and age, instead of the years that you had to hunt for a PDR on the floor. And now it's so wonderfully easy. That part of all that is good. Now, there are a few things I want to start with, and everything today is hodgepodge in that nothing flows. We don't, where we did IVs or blood. I'm just going to throw out things to show you. And one of the things I want to show you here is the stat lock. It's gotten real popular for IVs, central line IVs, and for catheters. Not the same kind. They still call them stat locks for both. I'll pass it around. You can see that it snaps around the tubings, and then it's sticky on the back that keeps it stationary for the portacath or for one of the central lines, and it's such that you can snap the tubing. It fits. So I'll pass the stat lock because now, before I do though, were you with us, Melanie, when we had the pad?
Yes.
And we learned something. This pad is just a slit pad, and we had to change the dressing on a central line Wednesday, and the reason was that they had not properly put this little pad was there, but it was sticking to opsite. And so if we pulled the opsite, it was going to pull, it just wasn't. Now we had a stat lock up here. So the student and I and Melanie, we all took it off and wore the mask and the whole thing. We were doing great, and we got a new one, and the student put it back on exactly like we saw it. And I think, I'm not sure why we did it exactly, because we were told to redo it. But
They came up without the stat lock on there, so she was.
that's right, it didn't have a stat lock. That's why we thought we were changing it, because it did not have the stat lock. Well, we did it beautifully. We put a stat lock on. And then we did the pad, just the pad with the, and we tried this writing. We tried to pull it off, but it wouldn't come off, so we said, well, I guess it's not supposed to, but we'll put it like that. Well, in IV therapy comes by doing auditing and finds us and tells us we did it just absolutely wrong. And so it was such a great moment for all of us to learn. And the students, when we really got this, it says, this side up. And the writing, that's what the writing said. And it's not to be taken off. And the reason the auditor knew it is we had the white side up, and it needed to be this side so it would not stick. Was that it?
And there's antimicrobial.
Yes, on the
other
back
side,
or
yeah.
something. There's some microbial ointment or something. But it just to help you all know, if you're visiting or you're home healthing or anything, and you see it needs to be the writing on the pad. Anything else, Robin, you or Melanie want to say about that? I'll pass it. And I just thought it was a great teaching, but we learn all the time. All of us. And then we've already talked about the stop costs. We passed those, I think. Why did I bring all this? I'm not sure. Yes, I know why. And then, of course, we've already talked central lines. I want to go over the board with you again. But this is the pick, just to remind you, peripherally inserted. And usually if they're purple, they're called the power pick, which means they don't need another one for dyes. If they go downstairs to have some kind of dye, it really upset patients to have us have to give start a peripheral ID when they have this IV when they have this in. But unless it was purple, it wasn't power pick. So with that, I don't know that I need to pass that. I'll just keep it here. The other thing I brought from clinical was I just wanted to, you see them, the Hemo Occult pads, and they were taken away from us. They're still on the floor, so the trouble is you can get these real easy for finding occult or blood in the feces, the mucus, the GI. These they don't mind parting with these from the lab. They don't want to part with the reactant. Well, it's a horse and a carriage. You can't get anywhere without without them both. But I do want to tell you, because sometimes a nurse hides some reactant just kind of for our own curiosity. Maybe you're changing a canister and it just smells like blood. It just has this blood. Doesn't look like it, but your nose just knows it's blood. Then if you've confiscated a reactant or something, quietly you could check it. And then quietly tell a physician, don't you want to run a test? I think they were taken away from us for money. I mean, I think, you know, the lab doesn't get any money if we do it. But I want to tell you, just in case you do it, just to remind you, if you recall, one flap has the 2 windows, and I'll pass it. And it's for you to put your specimen, smear it, and if it's feces, just break a tongue blade and take a smear, and then the other end of the other tongue blade, another spot of the feces, because it may be a hemorrhoid. And if you do one sweep and they're both going to be bloody. So get them from 2 spots of the feces and just wipe. Then you're through with the feces part. Turn to the other side, and you can't see it, but I'll pass it. You can see through the paper your stain. And then you see the 2 little dots, and you put the reactant on the 2 dots. That's your control. And then the shadow, put a dot and a dot. And if either one of those look like the one dot that is controlled, that will turn blue, because it's going to turn blue because it's your control. And they have one beside it to show the difference, so that you think it kind of looks blue. Well, look at the one beside it. Unless if it's white and this is a different color, it is probably blue. And if it's blue and blue, they've got blood in whatever that specimen was. So I know you remember it, don't you? It's still out there. It's still being done. As I said, sometimes we have to clandestinely get occult blood. How's that? Then I wanted to go over, just not that you particularly need to know, but you know, it's real easy. A syringe, you aspirate and give. But sometimes they come pre-ready. And it used to be, I don't know if you're old enough for the Tubex apparatus. It was a Tubex. It was an equipment that fit on ready-made. This drug is a narcotic, and it came to us individual. So we break the end and bring out the syringe, and then just take the cap off, and that cap can go in your port, and you push. Well, we got to have something to push it with. Some nurses get something and just push the stopper. We used to the floors used to keep kind of a Tubex system. It fit around it, and you were able to push your IV. But they also gave us an alternative, and that was to pop that off and just put a syringe in there. And don't put air, because the stopper will come flying out with the medicine. So you just put your syringe in and transfer it from here to the syringe. So I'm going to just pass it for you to just kind of see, but you'll be so smart if you're someplace and nobody knows what is this and how does it work. So there's those. Now, I think I'll get into more serious stuff than little hands-on there. I'm going to start with, I'll start with catheterizations, and you can go to YouTube and get great views of catheterizations. The one thing that they have added, they've just added this, and I don't have it here, but you probably could go on YouTube and see it. When you open a catheter kit, apparently their statistics are horrible on infections, and so they have a little Ziploc bag that has a cloth and gloves, and that's your little hint. Put the gloves on, they're not sterile, necessarily. Put the gloves on and take this cloth and clean them. And have you seen it, Ari? Have you seen it? Mm-hmm. And that's kind of new from years ago. Mm-hmm. And then the stat lock. is the other thing that's kind of new in the kit. But the kit still has something to clean the patient with. It may be swabs or it may be cotton balls. It still has the lubricant. Either you twist off and squirt, or it's just the envelope. So they're all a little different, but they're basically the same. And then they have something like a syringe for blowing your bulb up, and of course gloves. I particularly don't. I'm teaching the class, so you get my biases, but I'm not real fond of all that, the towels, and I don't have these layered good. When you open your catheter kit, they have, the first thing is a towel, fenestrated. You can take it and put it over the patient, under the patient. You can do all that. They got them there for you. Just pick them up in the middle so you don't touch your sterile tray insides, or what's inside. And when you put it under the patient, just make sure what's facing up is sterile. That's why I don't use them. They fall. They're to me, it's just opening up for contamination, I think. So I just pick them up and put them over here. Then the gloves are there, and the first thing I would do is put on the gloves sterilely. And of course, review if you need to. Cuff can be, these are sterile. The cuff can be touched all you want to on the outside. On the inside, make sure you go under the cuff. And see, I like all 4 fingers under the cuff, but don't get that thumb in the way as I'm putting them on. You know, people will do this and then the thumb has just been contaminated. So make sure you stay out and the thumb is out, and I'm good. And then do everything you've got to do in here. Now I'm gonna just break sterility a minute, and with you all. In the kit, under this tray, so I've fixed everything. I wanna open my swabs, and if it's cotton balls, open whatever and pour over it. Then and I pick it up in the middle, not the outside, but I'm sterile. So pick it up in the middle. Maybe you need to help me here, because you're not seeing, the film isn't showing anything. So then pick up in the middle, put it over here, and the catheter and bag are in the bottom of the box. Take the saline, I'm still sterile. The catheter's sterile, attach them, and check your bulb. Now, if somebody said they're not doing that now, you say, I know. Because they've now sent that we do not need to check the bulb. I know. Why? Why not? So I still do it. Because I'd hate to put it in and
Find out it doesn't work.
Yeah. So what does that cost you to do that? To check the bulb. So check your bulb, knowing that they're saying we don't have to. Then you'll want to, this is all still in the box, lubricate the end, and then leave it in the box. And I usually leave the syringe on the catheter and lay it in the box. Now I'm still sterile, everything's sterile, and now go to the patient's labia, if it's a woman, and open her labia and look. And sometimes, if I think it's going to be a real challenge, I'll take Q-tips and open them in my sterile field. Or have them ready to. Just because if you think for a woman and you open the labia, there are all kinds of dimples, and the clitoris is right there, then the meatus, vagina, am I right? And this rectum. So clitoris, meatus, vaginal, anus. And they're all not just perfect, as you know. So the clitoris is the biggest giveaway, and the vagina, of course. So when you open the labia, you can do that. You've lost your hand anyway. So just keep looking to see what you think it is. And then pick up your swabs, whichever you're using, whether it's, we'll say, the swabs or the cotton balls with your forceps. And I'm not big on side to side. I don't mind you doing one side of the labia and throwing it, and another side and throwing it. But let's don't spend any more time on the sides. I'm more interested in the insertion area. And start at the clitoris. No. The media says start at the clitoris and come down. Well, why drag germs from the clitoris? I love to go straight, what I think is the meatus, straight in and down. So I don't drag germs from the clitoris down. So, and if I've got another one, go straight in again and down. If I've got another one, one more. But as you turn to work on your tray, don't let your fingers go together. I know you just wiped side to side, but still try your best to keep it open, however you like to keep open the meatus. Then what you think is I think it is, if you need to get a Q-tip and push and see if it stops right there. And it is so hard, and especially pregnant women, it's swollen. But you do the best you can. So the lubricated catheter, start, and it's good to start up because it's a little moist anyway, and if you start kind of with a downward, it's going to slip right into the vagina. And I know this is all review to you, but I'm holding it with my hands because I'm sterile with this hand. So aim up and just keep going, and my clue is the urine. I'm watching that completely. But don't let the labia go together because it drags, and I don't think the labia is that clean, and I'm going to push it up into the bladder. As soon as I see urine, stop. Now I can use my unsterile hand to hold and get you kind of need to hold here as you push the bulb up into their body, and keep your finger on it so that you can, otherwise it comes back on you, remember. This one's peculiar, but and of course then pull it out so that the bulb will be at the neck of the bladder. Now, I wanted to say one more thing on that. That's a woman, of course. Now, I just can't emphasize enough that this is your trick, to see urine here. You can say she's dehydrated. You can say, hadn't drunk in days. I'm telling you, I don't care. You're going to get urine. And I had to learn that because sometimes, one time, it just happens about once, that kind of thing, I saw what I thought was urine. We finished, everything nice. Well, we went back, she had no urine, an hour later. And then I realized the ointment some of it had gotten on there, and that's what I thought was urine. So we weren't there. I don't know where we were, but we weren't in the bladder. And so just make sure it is urine you're seeing. Now, the man, and that's opposite. I mean, we can walk off and not see urine here in the tube of the man. So let's go to a man now. Same thing, same kit. Pick it up in the middle, put it over here. You've lubricated, you've checked your bulb, and now you're ready to lose this hand. Where we open the labia, you'll now take the shaft of the penis, and as straight as you can do. I even pull up a little on it. If he's not circumcised, then use this hand to pull the foreskin back. And you've got to pull it back to get to the meatus. Pick your forceps up with your, and again I go to the insertion and out. That's where I want to take germs away from. So insertion and out. I want the germs away from that center. Then this is lubricated, and start in. All you need to say is I'm putting in the catheter now. And the word is it's uncomfortable, but it shouldn't hurt. Now it's reached the prostate. I know it does because I've met resistance. And it's the craziest phenomenon, but sometimes I've found when I hit it, the prostate, you just give a gentle push, try to push through the prostate. It's not going real good because obviously it's gone against the side of the prostate. So bring it back a little and try it again. And here's what's crazy is if I shut my eyes, I can feel by shutting my eyes. Isn't that crazy? Mm-hmm. But if you shut your eyes, you can better feel which directions it's trying to go to. And if it's going over that direction, I can tell because my eyes are shut and I can just feel it better without that sensory stimulated. And I can tell it's going to a different direction, so I'm going to overcorrect this time. I'm going to bring it out a little, and because it's inclined to go toward me, I'm going to aim it over toward the other way. It's worked several times that way. Once I don't see any urine, but his penis head is up to here, hello, and I still don't see any urine. That's all right. He's lying there watching TV, or he'd be choking, he'd be screaming. So the fact he's doing fine and I don't see any grimaced face, I'm going to blow the bulb up. And that didn't waken him up either. So that isn't screaming, and so I know I'm in. So much easier for the man. And so I still don't see urine. I remember working one night, and it was in my early years, and they wanted men to try to catheterize men. And this fella came, male tech. He said, I've tried 4 or 5 times, I just can't do it. And it was because he wasn't getting urine. Well, and see what happens is that penis and prostate, a foreign substance is being introduced, and the body doesn't like it, so it spasms and it's trying to get rid of it, so it clamps down. And in clamping down, I don't get urine. So you hang it over to the side of the bed. Pretty sure you're in. I promise in 20 minutes you go back and you've got urine. Now, the beautiful thing, and you'll find it in your briefs, but I'm not sure if it's terms or data, the Crude. I think it's in there. Crude, C-R-O-U-D-E with the French mark. Crude. I think it's in there. It's under terms or equipment. And if you have it, find it, bellow out. But it's a it's a red tip catheter with a crooked end. And can you see the crooked end? And I'm so sorry I can't say 100%. This has absolutely worked 99.9 times when a catheter just won't go in. For a man especially, let's say I'm trying to catheterize a man, and I get to that prostate and I can't get through it, and I give it a little power, but it just won't go. I bring it back, I do my closed eyes and feel with my mind, and it's just not, well, you got it, because I keep pushing, he's bleeding now. And so it's irritated now, and with irritation, it's going to begin to swell a little. So I've got a mess going on because I can't get it through, and I've irritated it irritated the tissue. And so I just walked right out and asked to order me a Cruday. And as I said, I could almost tell you 100% in 52 years, it has never failed me but one time. And I wish I could say 100%. But for whatever reason, it was a doctor that invented it. I don't know why that little crook except that it just, by that little turn, it finds the right spot to go through. And it's especially, well, it's good for women too, but just take the regular catheter off and put the Cruday on. You don't need a are anybody finding it? Yeah, I thought it was
I
there.
didn't see it.
Not finding it. But anyway, you probably won't forget Cruday. And it, C-R-O-U-D-E with the French mark over the E. And so put it on, treat it just like a catheter. And I don't do it unless I've had trouble with the real catheter. And because you order them special. And it'll just go through. And it did that. It's done it all these years. For a woman, it's the same thing. You know, I just can't get it. I see where there is a meatus, I think, but as soon as I put it in, it slips down into the vagina. And the Cruday is so good at going in, and so it's good for women too. But the person that we lost it, the only one that has never worked. He weighed about 400 pounds, and and I think I've told you, it's not, I want to give her credit, Lucille Osserbrook at Vanderbilt, she taught nurses anatomy and physiology, and she says when people gain weight, the one place they don't gain is eyelids and penis. And that's the only two places that will never gain weight. And you know, that's pretty neat on the creator's part. Because if you had fat eyelids, you could see. That would be rough, wouldn't it? So anyway.
A lot of blind people. A lot of blind people. Except for
A lot of blind people, that's right. So the penis, I don't care how big you are, the penis is still the same size as adolescents or whatever. So you have a very large man and a very small penis that you've got to work with. And he only needed catheterizations because he was hard to ambulate or hard to move. He weighed a lot. He needed a Lasix. He was going down for x-ray, and they wanted him as dehydrated as they could get him for this x-ray. And so that's the only reason. It wasn't for anything else, and it was going to stay in because he had so much Lasix. And so it just wouldn't work. We traumatized. He was bleeding, and I ordered a Cruday, and it's the only one I ever lost. And I'm just sad to have to report it. But I guess it's good to say it doesn't always work. But it's the only time it hadn't worked. And he we had to call the doctor and say, we just can't get it in. And he said, just leave it. Now, the worst part is it meant he got out of bed and would have to lean against the wall, and you had to get up under him with a urinal and help him urinal. And it would have been easier with catheter. Anyway, that's my one time it didn't work. Now, the next thing I want to do is, so just again, the box, the catheter, I do want to mention the side port for getting a specimen. It could be this one, you put a syringe in, you know, I need a specimen. So if you don't have hemostats on you, put a rubber band right there and leave it for about 30 minutes so your urine is fresh. And then put your syringe at the port and aspirate your fresh urine. This one, you use a syringe. This one has a little disc, and they want you to use a needle and get it. So they've got a spot for you to get the specimen. Just don't get the specimen from the not dirty, but the old, several hours old, was it has had a chance to grow it. Now I think, now I do want to say that with saying that, of course, the urometer is, they're urinating into the urometer, and you may be wanting to keep up with hourly. And so you register that hourly, just raise it, and it goes into the bag. So you could go into the bag and collect urine for this hour in here, and then push this button and it comes out right there. The only thing about it is this has been in for 3 days, so it's probably grown something in here. But the tubing has too, so you know nothing's perfect. So, but that's that.
Do they still use the Texas catheter? Is that
Yeah, Texas catheter, yes, and you know, the Texas catheter, which is the condom catheter and the wonderful thing about the Texas catheter is that it's not invasive, and so they can urinate. It's not skin problems. The only thing about them is that you need to be comatose if you wear them.
Really? They can pull
They
up
just, I don't care. You can pull it as tight as you want, the tape around, and cut circulation off. And it's still going to twist and leak and the whole thing. But, and so they're great for comatose people, but that to me is about it. Just like, now did we talk last week, I don't think we did, on the Pure Wick, the Pure Wick. Okay, we're gonna break in a minute, and I wanna go get a Pure Wick. And I can describe it, because I think about it. I'm thinking about it about like the Texas catheter. Now, if you check the Texas catheter and turn them, and just make sure every 2 hours that it is straight. But if they're moving at all, it's going to twist and turn and come off and so forth. The Pure Wick, I want to show you in a few minutes when we break. I'll go get one for you. But they said a man taking care of his wife at home was changing her so often. Her skin was getting in bad shape, and he invented it. Now, I was talking to a friend of mine. We think we could have improved it, but it is like a hot dog, hard plastic. You all use them?
Yes.
It's a hard plastic like hot dog, and in the middle of it is scooped out a sponge, and it's on a tube like a catheter at the end, and you put it between the labia of a woman. It's just for a woman. With the sponge or the soak up, it's like a tampon fit in a plastic container, and it goes between the legs, and then there's suction on it, or drain. You know, it's suction, isn't
Suction.
it? Suction. And, the idea is when she urinates, it goes on that, and goes on that sponge. Now, we had one the other day, and the student, I was very proud, when she checked it, she saw it had cut the perineum. Well, you were here, weren't you?
And she said, there was a language barrier too, but she said she wanted it off and she wanted a diaper.
So that was
she
the hard
hated it.
plastic cutting it.
Yeah, it made a sore around
Yeah.
her.
And so y'all removed it, but I don't think anybody had looked and seen that till the student saw it. And my colleague at Centennial, we were talking about it, and he was saying, you know what it needs to be? Not hard plastic, but more like the mask of a CPAP, that kind of plastic.
Flexible plastic.
We said we should have invented that, but you know, a man did it.
They don't know.
And, now, my students work as techs, and they say they're wonderful, but they gotta be placed right, and you really need to check them every 2 hours. You really can't just put it there and think it's taken care of. So, it's almost to me like the Texas catheter, if they're flipping and floating
If they move
about,
around, it's out of
yeah,
place.
it's
right?
not gonna work. Have you dealt with them, Daisy, much?
No, I seen one, but I never
Yeah.
had hands.
Ari,
on
have
it.
you dealt with them much?
Yeah.
What do you think
Two
of?
times. Not the greatest.
Yeah.
Because you know when patient moving them by.
And that woman had a bowel movement too, so
Oh.
that wasn't helping.
That's exactly what they said, yeah, if they're loose of stool or anything like that,
And
yeah.
then it's moving around,
All right.
it's like-
So, let's break, I'll come back with one to show you, break. All right, back from break, I couldn't find, they're out of Pure Wicks. I'll maybe bring one another time and show you. So I wanna rapidly continue. The portable sitz bath. The only thing about sitz baths is that they help circulation. We don't want real hot water, but you fill your enema bucket in a bag. I mean, it's like an enema bag. And it has the clamp. You put this on the commode and the overflow, and they sit on it, and hang that on the door hook and open it. Don't gush it, just a trickle, and the water will cleanse and stimulate by just the warmness of the water. Sitz baths, I think, are underrated. I think they're good. They clean, they stimulate. There's just even the pressure of something pushing against, and then put a little warmth to it. And I think I've already been on my soapbox about OB and deliveries not doing heat and sitz baths after deliveries. That's been dropped, and I express myself every time I can about it, and I don't even do research. You just cannot tell me that the end result, it wouldn't be better to continue what we used to do in the old days, which was they did a little sitz bath, got in bed, the sheet with a heat lamp, and that heat stimulating and circulating, and I just don't think we had as many problems, but I don't have research on it, so something to think about. You do the research. Then I want to go next into, and the Texas catheter that we talked about, still, visual. I do want to mention, I'm not seeing, I bet in the last year, I have not seen the vials. I don't know whether we've quit them. I don't know whether Puerto Rico, with the storms and the floods, we're doing it, because a lot of our medicines changed when our pharmaceuticals in some of the countries have been devastated with floods and things. We've changed, but I have not broken an amp in over a year. And I just want to say, in doing it, take the tip in, make a circle with your, some people thump it, that's okay, but if you take the end and make a circle with your wrist, it'll clear down. Wrap the alcohol completely around it. Hand me one of those. Thanks, Will. Take the alcohol, go completely around it, and then put your fingers on the alcohol and pop towards you, because you don't want to cut your finger. But as I said, I'm not seeing them much now. The other thing I'm not seeing so much of, you're not either, colostomies, because they've decided, well, that they just find, I don't know whether research has shown that they do about as well to not have the, now if it's in, not have a colostomy, if it's an enraged gut and they had to take a mass and they just don't, they think the anastomosing won't, it's just too swollen, too angry, then they'll do a colostomy. But they will go back. It won't be permanent unless it's too near the rectum or someplace. Wherever it is, they may have it permanent. But more often than not, they're not being permanent. They're going in when everything's healed and reattach.
Yeah, in Green Hill, where I work at, I'm their wound care person too, but we do have 2 people that have the colostomy, but those are permanent.
Permanent.
Yeah.
Were they done years ago to permanent? You know, you don't know.
Well, this one person is fairly new, and I'm thinking this other lady, she came from far seas, because they don't even speak English. They only relate to me because her last name means black. So, but they don't speak clear English, but where she came from, they had a colostomy, so they just,
Yeah, they have just decided that maybe they do just as well, and then they reattach. So I'm telling you, you're going to still see them, as Daisy has. The other thing, now the thing they're getting away from, and I wish I had been industrial enough to write a paper or something, is irrigations. I used to always think, common sense, why do we irrigate a colostomy? They're never constipated, and why are we irrigating them? So that it flows good. And I always thought, this is the oddest thing. We do it every day, or the patient does. It takes electrolytes out. So why is that? Well, they don't do them now much. They will post-surgery maybe once. Are y'all irrigating those? No. See, But I am going to run through it real quick, and you can always YouTube it too. It's just an enema on the side, is all it is. But I do want to go over it. But it may be that such that I'll never go over it after a while, except occasionally we do still do them. And let's say the patient had a mass, they have a colostomy, and they came back to the floor with just a pad around the stoma that just a one-timer, and they real popular are the brackets that will close it, because otherwise it's open. So this is just post-surgery. And the physician says irrigate till morning, or 24 hours, irrigate. And they think that's up to you to do. They may say soap suds, I doubt it. They may say, they could say soap suds, or they could just say tap water. They just to keep it clean, because so it's post-surgery. Their surgery was done yesterday. This is the next morning. They're post-op one day. They're weak, and so you need to irrigate. You order an irrigation kit, and in it is layered just what you need, so you don't have to worry about that. I'm going to take this off, but I'll probably put on a wafer and go on and cut it to the size of your stoma. And she's just laying in bed because she's just weak. I am going to get her up because it's post-op day 1. So I am going to get her up, but I don't want to expend all her energy. So as much as you can conserve her energy, his or her. So clean good, put the wafer on. You've already cut the hole to fit your stoma. and you've put it on now, so that your bag in here is gonna fit like Tupperware. You know, now it's gonna fit. This one is gonna stay better than the one-timer that came up from surgery. So we're not gonna put it on now because he asked us to irrigate. So in this kit, next is the sleeve to irrigate. And so you take the sleeve, put it on like Tupperware. It's opened at the top. And in there is also what looks like the enema bag that you're going to irrigate with. So I have put this on like Tupperware, and I go get lukewarm water and fill my bag. And it's like any enema, you can run fluid through. You know, an IV, we're absolutely going to get the air out of the tubing. Don't have to for an enema or an irrigation, because the air is going to stimulate, and that's all. The only reason I want to do it is stimulation. So, and see, this doesn't look like an enema because it's got a cone, because an enema, they've got a sphincter, but I don't have a sphincter at the stoma. So I put my water in here, I hang it on the IV pole or wherever, and I get the patient out of bed. They need to get up anyway. Bedside commode, and now take my gloved hand and lubricate it. Lube is in here. Lubricate my fingers, and I'm gonna go in the top of my sleeve to the stoma. And I start with the little finger, go in the stoma. You also can feel which direction the stoma is going by putting your finger in. Feel it. Put your next finger being the thumb the biggest, and you're stretching your stoma. Now I can put the cone in. Lubricate it, put it in the stoma, and open my clamp. And do it, and the end of the sleeve is between their legs into the commode.
Okay.
And so now, so I don't put a stopper on, I start my cleansing. And that's when I would think, I'm just running electrolytes down the commode. And then somebody else who really got on it did something about it and got it changed. So the doctor wants to leave that gut real good and clean, so may want to do it a couple of times this first post-op day, because after surgery. So I finished. And you can't tell them to hold it, because they can't. They have no sphincter. But I finished. Now I didn't just zip it in 3 minutes. I like to go slow. It's warm, just slow. Now take it out. She's getting awfully tired. And I'm hoping to give a bath while she was sitting there. They may be able to just sit there and let you do a sponge bath and get in a clean bed if they've got that much time, or you can do that. But she expelled what I put into her bedside commode. But she said, I've got to get back to bed. I've just got to get back to bed. Then turn your bag, Ziploc bag. It's really not Ziploc. Some of them are. Turn it over, put your stopper on the end, and let her get back to bed. And then put the end in your bedpan and let her lay down and open again and let it drain while she's in bed. You can come up with things yourself. Just work with the patient. So she's through. We're through. We're pretty sure all the irrigant is out. So take the sleeve off and put your bag that has the Tupperware and the clamp it. And you have to, she's going to lay in bed all day, put it on a little angled. And put your clamp on, and she's ready. Some people, if they've got a lot of flatus, put one little air prick. so that the gas won't explode it. And also, kind of what Daisy said, they may come in, already have one, but you still need to help them with it. I had a patient, he was in for something else, he was ambulatory, but that was a daily thing, he had to do it. So I always tell them, now I know how to irrigate a stoma, but I'd like to do it the way you do it, and have done it for 20 years. So he was big, he told me how much fluid, and I always ask him, I said, I don't want them to think I don't know how to do it. I do know how to do it, but I want to do it their way. And I told him, I said, how much fluid? He said, I put 1,500. So we did that. And then he's sitting on a stool, well, his commode. And we do it. And then he said, all right, little lady, you just leave me alone for about 30 minutes and bring me my bucket for his chewing tobacco spit. And he said he was going to chew his tobacco for about 30 minutes and then he'd be ready. So he knew how long he needed for peristalsis to take place. And yeah, I want them to do it their way, and you do too.
Yeah, because that patient, they're from India somewhere, they don't speak English, but everybody else that came in, they had a problem. So I said to the daughter, I was like, show me your way.
Yeah.
And I watched them, then I did it my professional way too. And that's what they like. So then I don't go there every day. So like, where's Daisy? I'm like,
Yeah,
I'm
they like
somewhere
to do
else.
it their way.
But you gotta let them be comfortable and do it their way.
Their way. That's right.
It still end up the same, it's still the same cost, but
Yeah,
they're comfortable because
let them do it their way.
you gotta wipe her, then you gotta talk to her, then you gotta it's like a whole process,
Yeah.
but it's patience. But
Yeah.
that's their one. So.
Now, I just want to bring this up, the different 50 milliliter syringes and catheter tip fits a catheter. It's not really a lure lock, but it would fit a needle, but it doesn't lock. I call it lure lock or a needle. And then of course the bulb is a catheter tip. And usually all bulb syringes are catheter tip. I'm not as fond of bulbs as the others because there's not much control. But they come, and a lot of times I tell students just take them home and baste your turkey with them because you just have no control. Now, the Salem sump. I want to talk about the Salem sump. It is 2 lumens. This is 2 lumens, 2 tubes in one. And to the side, we see the 1 lumen, and then this is the air lumen. That lumen has to have air to the outside. The other they're both down in the gastric contents, but the bigger one is pulling fluid into a canister on suction, and this one is just providing air so I can do that. Because if I just have a 1 tube into my GI, then I've got a vacuum. If it's on suction and it's 1 tube, I've got a vacuum and nothing's gonna work on a vacuum. I need the air to make it work with suction. So somebody invented it, and it's a great thing. If it was 1 tube, it would be it'd be a feeding, we'd make it a feeding tube, and it'd be on a pump, and we're going to talk about that in a minute. And I can make a Salem sump a feeding tube if I tie the air tubing off, then I do just have 1 tube, because I've just taken away my air tube. And sometimes the physicians will say, let's try feeding, let's introduce some fluids, turn off the suction, and let's make it a feeding tube for a little while and see if they can stand it rather than pull it out and put a feeding tube in. Now, here's the deal. It's for decompression. A Salem sump is not for feeding, unless we twist it. it is for bringing contents out, but either because you're not digesting, you've got a mass that's obstructing, for whatever reason, you're vomiting all the time, and so the physician says put in a Salem sump. And so we're going to do that and then attach it to the wall suction canister and collect the gastric contents. And that's where, again, I remind you, don't put a piece of tape on the canister. Take out the lining, pour it out into a hard container, as we always do, and then reuse it. You can rinse it if you want to. Put it back in the canister, the suction, and we're back to our suction. Now, let's go first with the insertion. And again, U-tubes would have the insertion of an NG tube. Take the end, order an NG tube, lobe of the ear to nose to xiphoid, and put your courtesy tape. Remember, I've gone over courtesy tape with you, where it's back to back, so I can put it right there. That's where I'm going to pass it to. Then I can just easily take it off. So I lubricate with the water-soluble ointment, not Vaseline, because it's oil and they're glunky nose, nares. They can't breathe when I got there. Got the NG tube in great, but they can't breathe. But if it's water-soluble, KY, it'll evaporate. So I then ask if they were broken either nares, either side of their nose. Then and some people put a little ice in a bucket, in a thing, and get it real cold, it's stiff. Others, what I like to do is take the medicine cup with ice and my hands are clean, I've got gloves on, and have them hold the medicine cup, or just put it over there and give them a little ice chunk. Tell them they're going to have control. That's the thing. This thing going down your throat and you're gagging, they have no control. And when you don't have control, you hold your breath, and it's just awful.
Yeah.
So tell them they're going to control. You're not going to push without telling them. And so give them a piece of ice, let them chew it, and tell them when you swallow is when I'm going to pass it. But I'm going to stop as soon as your swallow stops. So I've got this in ice. I give them an ice chip. They chew. I'm going on and tell them I'm going to the back of their nose. I'm not going to go in. And so I go in, that's easy. But now I've got resistance. So now take an ice cube, chew it, and as soon as you swallow, I'm going to advance it. So they swallow and advance. As soon as the swallows quit, I stop. Now let's rest, and tell them, let's rest. You can take another ice, and I'm not going to pass it this time. I'll just let you pass it, swallow it. And then when they're ready again, sometimes they just put up a finger when they're ready. Sometimes they close their eyes. I have them do whatever they want to. And so they swallow again, and I do it again till I come to my tape. And my tape, I want to go to my tape. They've done well. So wipe their nose with alcohol because it's got oil on it. And I need to tape my tubing to a dry nose that isn't oily. And you come up with your own way. I have my way, you can do your way. Usually piece of tape I split and put the tape and put the two splits around the tubing. Now I need to make sure, I'll promise if they let me do it, I'm in there, because I'll tell you why I know they won't. Take your catheter tip syringe, and they say again, they've dropped one of the three. We used to check 3 ways. Stethoscope on the xiphoid, and listen to swish. That's one. The other is aspirate gastric contents, which is the best one.
Yeah.
And the third, which they say they've dropped, is put it in water and see if it bubbles. They breathe in through it and they shouldn't be breathing because it should be in the GI tract. They say they've dropped that one and might as well because I'll tell you why in a minute. But I do them all three just because I learned them. And actually, if I get the gastric contents, I don't do another. I mean, you don't have all that in your lungs. So if I'm in, hook it up, put that pressure under 100. That's just always the motto. And last Wednesday we had a woman had been complaining of her GI system cramping, and I happened to look over and the suction was up at 185, 165 or something. And I asked why. She said, I don't know. And then I went out and asked the nurse, why is her suction on so high? And I said to the patient, your suction's up a little high, and I just didn't know if the doctor wanted it. She said, I don't know, but it's killing. We dropped it under 100 and she did fine. Went out and talked to the nurse, and the nurse says it's just so sensitive. And it is. You're trying to put it under 100 and you think it's there and you look and it's flipped over. It's just sensitive. Just make sure. I just never have known anybody to want suction. The doctor doesn't tell you. They just say to low wall suction. Well, that's under 100. So,
Just
you know,
keep checking it, right? Keep checking it.
yeah,
Right.
to make sure. Now, here's the deal. The thing is, a lot of nurses, I don't like them, but it's okay. They put these reflux valves on, blue to blue. Everything's always blue to blue. And you can see the air vents. So we've still got air. So we're fine. There's nothing wrong with these. Thing I don't like about them is the only reason anything backs up at the air vent is when it's stopped up by anything in the gastric. They're small holes, easy to stop them up with gastric. I thought we were decompensating. I thought we were decompressing. We are, but you may still have a little something in the stomach that sloughs off into these holes. And if it gets stopped up, it backs up into our safety valve, into our air vent. If it comes enough, it stops up our little air vents. It doesn't mess your bed up, but it's not suctioning good because it stopped them up. I usually take them off by the time I leave. Somebody's putting another one back on because nurses love them. If you don't have them on and it stops up, it pours on your bed, and they don't like that, and I get it. So if you do this, it's not going to pour on the bed, but it's not working either, and that's
So you
what I
can change
don't
it out.
like. That's what I don't like. So I don't mind them if you're going to nurse them, and that means check them. Ooh, I believe there's some color. And then you check your pigtail. If the pigtail if it has one drop across there, it's stopped up the air vent. And so what do? You take your catheter syringe and not put it here. I know it fits. You put it where the culprit is, which is the main stopping up. The main part's what's stopped up, not the air vent. And nurses, not seeing it now, so I'm hoping teachers are doing a good job of teaching. I used to see them flushing and irrigating where it was pouring out. That's not the problem. The problem is the main stick this, all stopped up. And so you put 30 milliliters of flush, and you can keep a record of how much or you can pull 30 back out and throw it away, and you don't have to keep a record. Now, story that I learned from, it was valuable. I hadn't been a nurse too long, but I had a patient, a young, attractive woman, who had the Salem Sump NG tube, and the physician wrote an order. Maintain the Salem Sump, Q4 hours, normal saline, or whatever. It can be sterile water, I think is what I'm saying, with 30 milliliters, irrigated. Fine, I knew what to do, just what I showed you. Keep a record of it. So I went in to do it, wrote, you got to do a task. So I went in to do it, and she had a visitor. And he was an older man, and it happened, he was a friend of the family. And he was in I tell you this because he was just so impeccably dressed. French cuffs, cufflinks, you know, the tie, the shirt, and he's visited with her. And I just spoke to him and went on and did my irrigation. Finished. I stopped the suction, irrigated with 30, put it back together, put the suction back on under 100, and started to walk out, and he says, wait just a minute, come here a minute. So I went over, and he takes his cufflinks out of his French cuffs, rolls his sleeves up, and he said, tell me what you just did. And I said, well, I irrigated. She has this tube. He was a retired physician. And I explained to him about the NG tube. And he said, okay, now let me tell you what you did. It was such a great lesson, and I think there are good nurses out there because of it. He said, it was stopped up. If it was stopped up, it got stopped up in the main, and he said post-nasal chunks can get in the GI system and stop it up. And all you did when you came in here was just pushed them back into the gastric area. Finished. I'm done. I'll keep up with how many times I did that, 30, 34 times. When I empty I&O at 3 o'clock, I will subtract 30, 30, 30, 30 from her gastric, because that's not her, that was me. He said, so what you did, you just pushed anything that was stopped up back out in the floating area to be stopped up again. He said, that's the reason he did his cuffs up, rolled his sleeves up. He said, the better way is take your 30, put it here, hold, and do this. And he's so right. That pressure will tear up any little fragments. And he said, give it a good working, because you're breaking up that pressure. You're breaking up little particles. Then give it, attach it. And I promise y'all, if you have fluid backed up here, that's what you do. You take it, 30, put it here. It's dripping all over the bed or in here. If you will do what he said and do that, it goes, you almost have to walk away from that. It will shake the canister when it clears out. It takes it from here back to the GI and into your canister because it's open. Great lesson. I'm not sure I thanked him enough, but what a good lesson he taught me about the NG tube. And I think I told you that I had a student that wrote me. She went into rural Tennessee after she graduated. She said, oh, Miss Grubb, she said, I've tried to teach them about the Salem sump, but they want to irrigate here, and they tell me that we do things a little different than they do in Nashville. So anyway, just keep it. I am not seeing it like I used to. I used to see a styrofoam cup around here with tape because they didn't want it on their bed. I get it. That's not the problem. They've got a rope down their throat that's doing no good if the air vent is clipped off. And so it killed me when I walked, before people could get to the parking lot, I had gotten rid of the styrofoam cup that was irrigated, and it just goes, and it's clear. So I get emotional when I talk about it. Now, the Salem sump, but now let me ease into the feeding tube, and they come all kinds of forms, but the same way I've got to put this in any kind of different way, earlobe to nose to xiphoid, and put the tape on so you know how far to go. And you're going to put it in the same way, lubricate, ice chips. It's not as big, it'll still hit that gag reflex, so give them complete control. I'll never move it without your permission, and I'll stop. So once it's down, some of these drop-offs have the wire guide. I'm gonna tell you, I've seen them develop. When they first came out, they were so soft. And the wire was the reason we needed for the wire, because they were so soft, they wouldn't have gotten past the pallet or the uvula. They started making them a little bit tougher, but they didn't until we get them down. And what happened was they would pull them out. We'd save this wire guide and tape it to the top of the bed. But if they pulled it out, we just rethreaded, and everybody did it. You rethreaded, put it back down. What we didn't realize, it was so soft, we would make little holes because it was so soft. So then the drip into the lungs, and they died of aspiration. So they started making them thicker, and so then they started putting the radio opaque tip so it could be x-rayed to make sure it really was where they wanted it. They let us pass it, but then they wanted it checked x-ray. So that started happening. They are thicker. They still, I think some will go down without the guide wire, but most all of them still have a guide wire to send them down with. Most of the drop-offs, they want x-rayed, because the physician will send back word, advance it an inch. I want it a little deeper. I mean, it was great, but they want it a little further. So all that for the feeding tube, it's put on the pump, and the physician tells how much we want to give them per shift. Now, when I first got out of nursing school, the feeding tubes were a little bigger, and we did gravity periodic. Every 4 hours we fed 240, passed by a 40 of water. And we do it that way. Well, you already know the problem. Too much, regurgitate, aspirate. Regurgitate, aspirate. So that got unpopular. Of gravity feeding, it was called. And you just did it with the syringe and passed with water, and then you did your next task and went down the hall and you aspirate. So then the pumps came, and that was a beautiful day, because we could just give them a medicine cup an hour, 30 milliliters an hour. 30 milliliters an hour. That's not going to aspirate probably. We're great. But that's against nature, that your GI system is awake all the time. Nursing homes, then I think the modus at nursing homes is a lot of them do 20 hours off 2, and then 20, or off 2 and then all day, and midnight they're offered from 12 to 2. And what's really coming back is cyclic feedings. You let it happen at night, and then they're off during the day for 12 on, 12 off. And that's popular right now. I heard that they're going to go back to gravity. You know, we have that old thing, everything comes on back. Radios and podcasts, same old thing. It used to be radios, now it's podcasts. It's still listening to a radio. I've heard that gravity, and then we don't have the pumps, but they not as old as I am to know that we're going to overfill them. I'm not for that, but we overfill to get the job done, because we got 2 more or 3 more patients down the hall. So anyway, that being said, they don't like for us to feed them without an okay from x-ray. Now, if it's in the middle of the night and this patient keeps pulling it out, and I have to keep putting it in, it needs to be x-rayed every time. If I get a gastric, I'll pull it out. Some people don't pull it out till they get word from it will not puncture very much now. They're tough enough. But I'll just put this in and see if I get a whole thing of gastric fluid formula. I go on. And I charted. Did it without okay from x-ray, but got 50 milliliters of gastric white fluid. And you know that even. So, you know, I cover myself.
Right.
The thing I wanted to tell you on it, story, is we had a patient, 48 years old, very attractive, athletic looking, brown, and you could tell she was an athlete. She had pancreatic cancer and a very attentive husband, and she was dying. She was comatose, but she hadn't been, I mean, her body still looked great. And so they asked him, heroic. He didn't want feeding tube. I guess they decided nothing. And she's comatose. But one night she rallied, and the next morning he decided he did want her to be fed. And she's comatose. Well, you know what it's got to be. It's got to be the feeding tube. And he's just so attentive over her and loving her, and you know, she's out, but he's talking to her, and that was great. I thought he would not let the student, I never ask, and I feel like they're adults and they can say, I don't want a student. So I didn't ask. We walked in, and of course it's the student's first time, and I just acted like this is what we do. And so the student, we'd already gone over it, and he's on the other side of the bed just patting her and loving her, and the student does a great job. You can't direct her because she's comatose, but the guide wire's good. So she goes in, and the student's doing great. She is lying flat, and you know, she starts to gag, of course, and we stop to let her kind of get over her gag. She calms down some, and we get to the tape, wipe the nose, tape it, and I go on and pull the guide wire. As I said, a lot of people don't, but I do. I like to go on and kind of in my heart check before I call x-ray. So we get it down, and they'll gag, and they'll do that, but not for but a second. She kept on doing it. Well, the student I checked, we did her 3 things. We didn't win a one of them. Now that ought to tell you something. We aspirated, nothing. But I said, she hadn't eaten in a month, so I'm not going to get anything. And she continues to do this, not bad, but that retching. She just does it a little bit. Well, that's not right. And he and I have a statement, trust your feelings. Something isn't right. But we passed well. Now, I didn't win this one, aspiration. I put it in water and it did bubble. But I'm thinking it's because she's doing this and the diaphragm's squeezing on it. And that's why it's giving me some bubbles. And then the third one, which is air, I didn't hear it. Now that ought to be enough. I didn't win a one. But I rationalized every one of them. The reason I tell the story is you cannot rationalize. If you don't win, don't rationalize. So, and I have a thing, I can put that face on that everything's great. But I didn't care because I'm trying to decide. So I'm thinking, the student's by me, he's watching us. You know, they'll watch your face. And he said, you don't think it's in? Do you not think it's in? I said, well, I'm thinking. I'm thinking, and I'm not sure it is. Well, do you need to do it again? I said, well, I believe so. I believe we will do it again. And so we pulled it, and the student did it again. I thought he'd say, she's not going to do it, I want you to. But he didn't, because, you know, the student's doing a good job. Got it. Exactly the same thing, exactly. And you think, well, where is you? I mean, why didn't you quit? Well, I learned from it. I just rationalized and was sure it was in. So he's still watching us, and I'm not trying to act like it's in. We've called x-ray. but, you know, I can still pass it. They're gonna come up. They hadn't taken a picture yet. So finally, I just am so uneasy, which was enough. The fact I'm not feeling good about it. I told him, I said, I believe I'd like to try it one more time. Thought he'd hit the ceiling. He said, go ahead. Because I guess he would see her do that and he wanted her to quit, but we were the ones doing it. So I passed it, and I didn't do any better than the student. Did exactly like the student, and she did exactly the same thing. X-rays at the door, they take a picture. You truly say a little prayer, dear Lord, let it be in the GI tract and not the lungs. And so, sure enough, it comes back. It's at the bifurcation. Well, he threw a complete fit. Get somebody in here that knows what they're doing. We leave that room and tell the staff. They said, you've got to send somebody in. I'm sure he won't let us do it again. They said, we're not doing it either. So we'll call the doctor and tell him.
That is scary.
And so the doctor said, let's just send her downstairs for a fluoroscope where they would follow it, you know, with an X-ray machine, which is what they did. We left, we didn't see him, but had to come back the next day. And he was very apologetic. She had it in. He was very apologetic. We said, now listen, don't worry, it's your loved one. You want them to be comfortable. So he said, I don't know why they don't do that with everybody downstairs. I wanted to say, money, a fluoroscope for passing a tube. Anyway, she died the next day. But that story was so important to me, because if you're not winning, you're not winning. It isn't in there.
Yeah.
And that's when I realized, I don't care what, if you don't win the most important one, I don't care if they hadn't eaten in 2 years, you're going to get something back. The body just will hold a little something in that GI system. And so I share it to tell you, you got to win one, and you might as well win the best one of all, which is aspiration. Learned from it, which is why experience is kind of good, because you learn from it, and a lot of people have learned from it too. I think that's what I want to say on the tubing. Just want to point out the peg, the pick, it looks like a catheter. They're, you know, feeding, they go home with them, fed on the side. You know, the one is for blowing the bulb up. Another one is for the feeding itself, the middle one. The side one is for putting medicines or whatever. It is 1 lumen. It looks like, well, it's 2. It's the blow up bulb lumen, and then the 1 lumen, and this side goes into the 1 lumen, just keeps you from having to detach the feeding tube, and you can open and give your medicine through the side. It's controversial how often they're changed. I can't ever get an answer, so that tells you nobody quite goes by anything. The books may say 3 weeks, but you go out there in home health and they'll be in for almost years.
Yeah.
And anytime if they start smelling or they start growing into the tissue, they need to come out. But you can do it if you're home health. You can do it. Just take it out, clean, and put a Foley catheter in. It's nothing but a Foley catheter. See, that much looks just like a Foley catheter. You blow up the bulb and then feed through. And usually they're on home health, they're on gravity feedings because they're not going to aspirate. So pegs, picks, gastric tubes, but could be nothing but a catheter if you wanted to improvise. It seems like there was something else on the feeding tube. Any question on feeding, Salem sump for decompression? Now, I'm watching my clock because I'm going to have to let you all go early. No, you hate that. But, the feeding situations, I'm just gonna tell you, I went out to see if there was any feeding pump on the floor, and there isn't. No, to show you, maybe next week there will be. I'll ask again and we'll go see it. They're not complicated. You think, well, is it like the IV pumps that we've done? They're all different. The thing I tell students is, well, we've got to change this every 24. And because of Pseudomonas, and it's just got so much sugar in a formula. So before you do a thing, memorize the look of your pump. They're all a little different. And then open the door and see how it's threaded. That's all you have to do. And it usually has a marking on the side to show you how to thread it through. So just see how it's done with the old one, and then put your new one in and copy it. And that's all I'm going to say on the feeding. We used to have a real, pretty uniform type feeding. We don't know. Then, remember on catheterizations, I just want to remind you that for the catheters of urinary catheters, the smaller the number, the smaller the catheter, which is different than our IV numbers. So a 8, a 14, 16 gauge is a big lumen catheter for a, it's small. Which is the bigger? 20, the 12 small. 12 is small like a children's catheter. As the numbers get bigger, the lumen gets bigger, which is exactly opposite. For catheters in the IVs, the higher number, a 24, is a lot smaller than a 14, so it's exactly opposite. Now, just want to remind you, fracture pan. Somebody asked you, the bedpan that is small, those other big ones are huge, but remember the name is fracture pan. I did want to mention the enema, and I know you've done them or you know about them and all. I just have some things I want to say about it, and mainly because I give a good enema, and I just need to tell you that.
Is that a sub enema?
And you may have a bucket or the bag,
You need to get a
and
good one. Right?
do it lukewarm, anywhere from about 1,000. If the physician doesn't say may say give a soap suds enema, well, you know it's going to be 1,000. That's just the standard. A little warmer than warm water, because by the time you get all situated, it's going to cool down some. Put your soap pads that came with it and hang it on the door. You're going to do it in bed. They say put them on their left side in the fetal position. And then you've got gloves, you've got this hanging up. You've got the clamp to work with. I like my hemostats. When I started, I think I told you when I started nursing school, they made us get scissors and hemostats. I don't think I ever used them for a year or two. And then once I started nursing, I see why they wanted us to do it. And I like the hemostats because you can just keep them right there. And this is so slicky, and it's got soap on it, and you just have a time. Where with hemostats, click, tighter, let it up. So lubricate with KY, water soluble. And in nursing school, I learned 1.5 inches. I never will forget it. Never have done 1.5 inches. Go all the way till you meet feces. 1.5 inches, and it's stimulating, but go on up where the feces is. So
Go ahead. Go for it.
Go for it. So go on up till you meet resistance. Now the problem is sometimes it embeds in the feces. So I open my clamp, and if the fluid is not going down, then I may need to pull it out a little, and it may then. So that's hanging up. I'm not having to hold it. This is where my control is. To hold it in the, you want to pass the sphincter. To hold it there, and I'm right-handed, so use my hemostats with the right hand and keep it in. And here's where I'm so good.
The best.
Yeah, the best is, I give a slow one, and I've never been cussed, and I think that speaks well, because I put them in imagery, and you'd think they'd kick me or say, get out of this room, because I started, and I tell them, now we're gonna go slow, and I'm gonna stop, and you can tell me if I need to stop, but I don't tell them, but you're gonna get it all. I'm gonna give it all, because it stimulates. So here I am,
You gonna get that?
and I start, and I say, okay, so they're fine for a minute, you don't have to even talk. And so you're fine for a minute, and they say, okay, wait, that's enough, that's all I can have. So I clamp it, and I say, okay, now here's what I want you to do. I want you to think of an Easter parade, Macy's Easter parade. And you'd think they'd say, are you crazy? They're not. And I contend that for 1 second they do go to an Easter parade and get their mind off of it. And when they do that, I open it again. Slow. I don't do it full force, shooting it in. Just barely bring it up. And I love this one. I love. I tell them, and they say, so I'll do it. Now you've got to stop it. And so I stop it, and I say, okay, here's what I want you, the beach. I want you to think of the beach.
Water.
The
waves.
The sun is so on your skin. Your skin has got salt on it because the waves, the mist from the waves. Now you can't tell me that for a minute you're doing the same thing, and he is too, even though he's got this this enema going. And the students, if I'm doing it with a student, they get into it and they say, what's your very best vacation? And, I don't know, I can't remember. Well, think of one. They get into it too. Do you know, you'd think I would be cussed. I would, woman, get out of my face. Or, they have never done it, which is interesting, I think. But it's slow. Now, and also I tell them, they say, I can't hold it any longer. I have the fracture pan under their buttocks, and they say, okay, that's it, I can't hold it anymore. I say, yes, you've got to hold it, of course. And then they say, I can't. I say, well, I'm gonna kill you. I'm gonna kill you if you don't hold it. Of course, that isn't making them hold it. And they let it go, and of course you don't scold them, because they can't, they do, but you just don't give them permission to let it go. And so you have to empty, you have to sometimes come back, your bed's a mess. But the point is, it was a slow stimulation of warm water and soap that hopefully brings results. When they do give results, and it's going to be the same way as their irrigation, that you need to let them sit on the bedpan or under the bedpan for about 30 minutes because of peristalsis. Be sure and note amount, size, and color the best you can. You don't have to pick out the turds. Just look at it, and how much would go in a styrofoam cup? That's 180. Visualize. How much would go in a coffee cup or whatever? You just visualize, if I put it in there, what would it be?
A mess.
Yeah. Now, we've already been over the central line, but I just wanted to bring the board, because remember, the granddaddy of all, the one that's been around the longest, is your triple lumen, the triple lumen subclavian. We've talked about it. There it is. Red, white, and blue. To use red one first, white next, blue, only because it keeps it straight in your mind. Then the vas cath, which is, we pass that around for kidney dialysis, paralysis, I would say. The home and Hickman, remember they're silicone, we don't put tape on them. And remember, the Hickman is the one that is tunneled. That it's openings down here so that the opening isn't near the superior vena cava. So Hickman at home, silicone, no tape. Then the pick, and there's the pick that we just looked at, smaller, peripherally inserted. Stopcock we've talked about, and then the favorite of all, the Portacat. Remember the disc and the Huber or the passport needle. So I just wanted to go over that with you. I'll put it up here, let that be seen. And I think that, yeah, I think that's it. I do need to go, so the we'll start session 5, is it? And let's begin a little bit more on meds. So turn in your briefs to page 17, and top of the page is Bidurian. And Bidurian, it's not used as much as, but the point is how it all developed. Bidurian is administered for diabetics like insulin, but it isn't insulin, once a week. Go to page, it's still in the briefs, but go to page 21, and you see the second from the bottom,